Hello and welcome. I am Dr. Anil Joshi, Professor of Radiology, and we are in the series Learn Radiology Basics with Dr. Anil Joshi. In this, we have got different topics of radiology. They are from the X-rays, they are from the ultrasound, they are from CT or MR, and different series are made over them. The present series is on ultrasound. In that also more in specific, it is on scrotal sonography. Now by itself, scrotal sonography is a big topic. That's why we have divided it into 7 parts. Now this is the 7th part of the scrotal sonography covering different pathologies. In that we try to give a theoretical idea, we try to give a diagnostic criteria, clinical details, and then we tell how the radiological appearances help us to come to a reasonably good diagnosis or near the diagnosis what clinician want for helping the patient to get better faster. Now to start, let's go with the disclosure, acknowledgement and disclaimers. Almost all the illustrations cases are our own and they are from our own department, coming from many day-to-day workings. Now certain illustrations we have taken from the web which are royalty free and they are without any charges. Such material is used in this as only a descriptive material. Now let's go to the what this lecture series, how it is divided and what are the topics that is covered in different sections. On this gives you video number 1 to 7 and the topics which they have covered. At present we are in video 7. Now let's go to what are the epididymal cyst, then hematomas, testicular neoplasms, sperm granulomas. These topics will be covered in the present lecture. Now benign epididymal lesions. Now they are epididymal cyst. Now it is a penless cystic structure. Large cyst displaces the testicular. The testis is displaced inferiorly by a large cyst. The incidence is seen in 40% of the men. It is fairly high and contains lymphatic fluid. Now what are the sonographic appearances? It's a thin wall, well-defined lesion, strong posterior enhancement, then no internal echoes and multiplicity may be there or they may be unilocular. The multiplicity of the cyst occurs throughout the length of epididymis and that they indicate different etiologies. We are going to see it as the discussion advances. Now what are the cysts are? They are benign cysts are from tunica albuginica cyst, then tunica vaginalis cyst and intratesticular cyst. These are the benign cysts. Then tubular ectasia of the rat testis and cystic dysplasia. Now tubular ectasia we have covered in earlier lectures. Then there are epidermal cysts and abscesses. And what are the malignant cysts? They are non-seminomatous germ cell tumors, then necrosis or hemorrhage in tumors, then tubular obstruction by the tumor, that is mainly by the lymphoma. That condition we have to think when we are dealing with this. Now testicular cysts have following sonographic appearances. They are anechoic, they have got content which are anechoic, no signals from the content, then sharply defined borders and visible walls, no blood flow within or surrounding the cyst. That indicates a perfect. Now let's go to another entity, that is the sperm granulomas. Now probably they arises from the extravasation of the spermatozoa into the soft tissue surrounding the epidermis, producing necrotizing granulomatous response. Then these lesions may be painful or they may be asymptomatic. Mostly they are found in patients after vasectomy. May also be associated with prior epididymal infections or trauma. On USG, this appears as a solid hypoechoic or heterogeneous mass usually located in epididymis but may simulate an intratesticular lesion. Then chronic cases may contain calcifications. Epidermoid cyst. Epidermoid cyst is a benign, well-circumscribed tumor of germ cell origin representing 1% of all the testicular tumor. It is sonographically variable, generally well-defined, avascular mass, and may be multiple or it may be bilateral. Now, testicular cyst, let us go first to the simple cyst, that is a simple testicular cyst. Now, in the parenchyma of the testicle are usually incidental finding. They do not cause any symptoms, so during the examination they found as asymptomatically or asymptomatically patient, they can be an incidental finding. Number 2, they are solitary, anechoic, well circumscribed, round or oval lesions with increased through transmission, that is of the sound beam we are talking, and measure from 2 to 20 millimeter. The etiology is often idiopathic, however, they may represent sequelae from prior trauma or inflammation. Careful examination for solid or mural component is advisable in order not to miss a potentially malignant cystic lesion. So it must have a clear wall, it should not be vascularity inside, and there should not be any nodules attached to it. These must be identified with the help of ultrasound. Now let's come to the epidermoid cyst. They present as a non-tender small testicular nodule. They are commonly benign testicular masses, have no malignant potential. Epidermoid cysts are often referred to as the keratocytes due to their characteristic intraluminal keratin contents. The echogenic keratin can lead to a solid appearance on sonography. So one should be acquainted, familiar with such deceptive finding, and this can easily be overcome with the help of Doppler. So if you put a Doppler, a cyst will show no signals. Then Doppler evaluation, however, does not demonstrate internal echogenicity, since the keratin cyst, though appearing echogeny, contained clear fluid. So there are no Doppler signals and there is no vascularity demonstrated inside. In spite of being lesion, epidermoid cyst can often be indistinguished from it. That is a differential of epidermoid cyst and a malignant neoplasm such as teratomas. Now, epididymal cyst can occur anywhere within the epididymis and appear as a well circumscribed. Then there is a posterior acoustic enhancement due to their clear serous fluid contained, and unless symptomatic, these cysts are clinically irrelevant and there is no treatment necessary for that. Now these are the cases we are seeing. Now in first case, you can see though there is a cystic appearance, it has got multiple septi, though also the wall is not well defined. In same we are seeing enlarged epididymis. So it's the inflammatory epididymitis with fluid which is showing a septi. Here one has to be careful in interpreting this, because this is chronic or acute epididymitis with hydrocele having a septi. Now look at the second one. Here also we are getting enlarged epididymis and multiple cystic lesion. So though they are cystic, they are due to the chronic inflammatory process. Now here we are seeing clear-cut cystic lesion, right epididymal cyst and left epididymal cyst. Both sides there are bilaterally epididymal cyst. Here also the case is showing same. There are septi, there is some thickening of wall, and we are finding in left side, that is first one, well circumscribed and echoic lesion showing septi, and also there is some solid component in the right side lesion, that is on the left epididymis. So both side there is lesions, but both lesions shows different characteristics. Now here we are seeing cyst of epididymis, well circumscribed anechoic lesions which demonstrate posterior acoustic enhancement due to clear serous fluid. No difference, no difficulty whatsoever in putting them as the simple cyst. This is the cyst of epididymis, possibly post-inflammatory, since there are thick septies, irregular wall. Now, though most of the walls are well circumscribed, there are anechoic lesions seen which demonstrate posterior acoustic enhancement due to clear serous fluid. But certain portion of this cyst do show irregularity, and there are septi formation which ultimately indicate the overlying pathology could be chronic inflammatory. So this suggests not simple cyst but having chronic inflammatory process. Here also there are complicated epidermal cysts showing septi and clear content. The septation differentiates it from hydrocele. Now let's come to the next topic, that is neoplasm of testis. This is a diagrammatic representation that we are dividing into. First is scrotal tumors, then how the scrotal tumors will be further classified are the intratesticular, they are malignant, and extratesticular, which are benign and they are adult, but in children they are frequently malignant. Now extratesticular benign lesions we have covered in some other lecture, so here we are only concentrating on malignant testicular lesions. Now they are the most common malignancy in a young male. The risk factors include cryptorchidism, atrophy, testicular microlithiasis, Down syndrome, and sylvestral. Now extratesticular tumors are, which are already covered in some other lecture, are adenomatoid tumors, then less common are hemangiomas, lipomas, neurofibromas, and rhabdomyosarcomas. They are already covered in some other lecture. Now testicular tumors on sonography, they are, as far as sonography is concerned, it is highly sensitive, however it is non-specific, indicating it can detect the lesion but it never says whether they are really malignant or they are inflammatory or otherwise. So as far as etiology depiction is concerned, sonography is not as accurate, so it is non-specific but highly sensitive. Most of them are hypoechoic SOLs. The seminomas are homogeneous, then NHGCTs are heterogeneous. Then color Doppler has got no role as far as differentiating or as far as diagnosing them is concerned. It can detect it, but the further it has got no role. For staging we use CT, MRI, or chest radiograph can be taken just to know the metastasis. Now let's see the differentiating point of testicular tumor, that is germ cell tumors, seminomas, stromal tumors, Sertoli cells, Leydig cells, gonadoblastomas, and miscellaneous lesions are the germ cell tumors. The non-germ cell tumors are 5% NGCT, what we describe usually. Non-seminomatous germ cell tumors, then embryonal cell carcinomas, then teratomas, choriocarcinomas, endometrial sinus carcinomas, mixed NHGCTs, then metastasis, lymphoma, and leukemia is to end the list. Now let us come to seminoma. They present as mass, swelling, heaviness. Trauma may or may not be there, but often it is misleading. It can be misleading if there is a trauma and if we find these lesions. They can present as acute scrotum in 10% of the cases. Then endocrinopathies such as stromal tumors may be present, and the serum tumor markers, they are fairly sensitive, or they can really tell us whether seminomas are there. That is, the serum tumor markers are LDH, AFP, and HCG. These are the tumor markers. Now continuing seminoma, they are most common testicular malignancies. Then because of their high sensitivity to radiation and chemotherapy, seminomas have the best prognosis among the germ cell tumors. Now ultrasonographic findings, they appear as hypoechoic solid lesions with internal blood flow, which ranges from small lesion to masses that replaces the entire testicle. So the amount of testes or volume of the tumor involving testes differs, and that is what we are going to see in the multiple cases which we are going to see at the end of this description. Then metastasis to brain, lung, retroperitoneal lymph node via hematogenous and lymphatic spread are common in approximately 25% of the patient. The testicular seminomas are most common testicular tumors and account to approximately 45% of all primary testicular tumors. The seminomas can arise outside the testicle, most often within the anterior mediastinum. Now testicular metastasis, think of lymphoma, mostly non-Hodgkin lymphoma, then you can think of leukemia. Second most common are the acute leukemias. Then lymphoma usually metastasize to lung, prostate are common, and kidney, stomach and colon are also involved. Now we are seeing the cases. Here there is a necrotic lesion. Here history is important. This patient has undergone right-sided orchidectomy and the left testis is showing the lesion. So top on the list should be the metastatic lesion, though it is not common to get metastasis to opposite testes in case of seminomas. Note a large heterogeneously echogenic mass involving majority of the testes, that is the metastasis. Now here again we are saying non-homogeneous, then there are certain areas of increased echogenicity, making a heterogeneous mass involving majority of the testes. In this case, it is breaking open the capsule and extending to the outside. So not only if you see carefully the testes, it is heterogeneous. So majority of testes is involved in different stages, and the lower portion, caudal portion, is massively showing necrosis and extension, breaking open the capsule. Now these are few more cases of seminoma. Again, these are the seminoma cases as described. We are seeing all the findings. Now let's come to the next entity, that is the Fournier's gangrene. It's a rapidly progressing lesion. Necrotizing fasciitis is a polymicrobial lesion involving perineum and genital regions. Fournier gangrene is a urological emergency with mortality up to 50%. Then computative tomography remains the imaging modality of choice. However, there can be a ultrasound findings. What it shows is marked thickening of the scrotal skin, then multiple hyper-echogenic foci associated with shadowings, and subcutaneous gas formation is pathognomonic of Fournier's gangrene. Infarct of the testes are due to edema or inflammation. There will be increase in pressure resulting into blood flow causing infarction. The ultrasound will demonstrate absence of blood flow and surrounding reactive hyperemia in case of infarct. Now scrotal wall cellulitis or abscess. Scrotal wall infection findings are diabetic or immune compromised patients are more susceptible to the infection and scrotal wall cellulitis or abscess. Then ultrasonography, there will be thickening of the subcutaneous tissues and heterogeneity, increased blood flow on color Doppler study. Then the scrotal wall abscess on ultrasound may be detected, show a well-defined hypoechoic lesions which represent the small abscesses. Within the Doppler flow, without the Doppler flow, within the lesion are the necrotic areas. Now, what are the scrotal wall lesions? Grayscale ultrasonography shows an increased scrotal wall thickness in scrotal wall lesion, hypoechoic appearance, and increased vascular flow on color Doppler evaluation. A scrotal wall abscess may form a complication from scrotal wall cellulitis. Then presence of loculated fluid collection with irregular wall and low level internal echoes are in favor of scrotal wall lesions, that is the cellulitis. Then there is vascitis. Now, acute vascitis describe an inflammatory process of the vas deferens in boys, though through the penis that usually results from retrograde spread of the pathogenesis from the prostate, prostatic urethra or seminal vesicles. The most common pathogenesis are Haemophilus influenza and Escherichia coli, E. coli. Ultrasonography reveals a heterogeneously hypoechoic mass with the inguinal canal possibly extending towards the scrotal segment with demonstrate increased vascular flow. Now, these are the images of vascitis. Now, let's come to a conclusion. We have seen different pathologies of scrotum in different lectures. We have got totally 7 lectures in which we have covered multiple pathologies. In sum up, where we stand when the ultrasonography of scrotal masses is done. It's a non-invasive and rarely uncomfortable investigation. It is widely available, easy to use and less expensive. It is safe and without radiation. It can be a guideline for minimally invasive procedures. The testicular sonography plays vital role in case of clinically suspected pathogenesis of scrotum, scrotal wall, any inguinal swelling, and also in case of male infertility, it is of gold standard. So also in cases of hypospermia, azoospermia patients, it can also reveal potentially life-threatening disorders, so that appropriate steps can be taken and the patient can be saved. Then rapid diagnosis and initialization of treatment is vital for testicular salvage. The ultrasound is a well established as a first imaging modality for scrotal sonography. Till now, we have seen multiple lectures covering multiple topics about this scrotal sonography. We have seen that sonography plays a investigation of choice, first investigation of choice in these patients. A role of sonologist is extremely important because a lot of cases, a salvage, life-threatening situation warnings are given by a sonologist. It is extremely important that the art of scrotal sonography should be mastered so that the complication can be detected very fast. I thank you for giving me your valuable time for all these things. Please note, radiology is not a race. It's a process. Be a part of it and enjoy the feast of knowledge. I am Dr. Anil Joshi logging off. Till we meet again. Take care, do your best, master the art and be beneficial to the patient. Thank you. Take care.